Today, we will discuss pituitary adenoma, which are benign tumors arising from the anterior pituitary gland. They are the most common type of pituitary tumor and can present either by excess hormone secretion or by compression of surrounding structures. Epidemiology. Small pituitary tumors less than 4 mm are common and are found incidentally in about 10% of MRI scans, although only a small proportion become symptomatic. These tiny lesions are often called pituitary incidentalomas, meaning they are discovered accidentally when MRI is performed for another reason. Classification. Pituitary adenoma can be classified in two ways. According to size. According to hormone secretion. 1. Classification by size. Microadenoma. A microadenoma measures 10 mm or less. Because it is small, it usually does not produce pressure symptoms. If symptoms occur, they are mainly due to hormone hypersecretion. Macroadenoma. A macroadenoma measures more than 10 mm. As the tumor enlarges, it can produce hormonal abnormalities, compression of nearby structures, headache, visual disturbances, cranial nerve palsies, hypopituitarism. 2. Classification by hormone secretion. Pituitary adenoma are divided into A. Secretory adenoma, about 60%. These tumors produce excessive amounts of pituitary hormones, leading to hyperpituitarism. The common types include 1. Prolactinoma, 35 to 40%. This is the most common functioning pituitary adenoma. Excess prolactin causes galactorrhea, amenorrhea, infertility, hypogonadism, reduced libido. 2. Somatotroph adenoma, 10 to 15%. These tumors secrete growth hormone, GH. Clinical manifestations depend on age. Before epiphyseal closure, it will lead to gigantism. After epiphyseal closure, it will lead to acromegaly. 3. Corticotroph adenoma, 5 to 10%. These tumors produce excess ACTH, stimulating cortisol production by the adrenal cortex. The result is Cushing disease, which is the pituitary cause of Cushing syndrome. 4. Thyrotroph adenoma, less than 5%. These rare tumors secrete TSH, causing secondary hyperthyroidism. B. Non-secretory adenoma, 30 to 35%. These tumors do not produce clinically significant amounts of hormones. Patients may remain asymptomatic for a long time because there is no hormone excess. Symptoms usually appear only when the tumor becomes large enough to compress adjacent structures or the normal pituitary gland. Clinical features. The manifestations depend on both tumor size and whether it secretes hormones. Secretory microadenomas. Because they are small, they usually cause hyperpituitarism only, without pressure symptoms. Examples include acromegaly, prolactinoma, secretory macroadenomas. These patients develop hyperpituitarism plus mass effects. Examples of mass effects include headache, bitemporal hemianopia, diplopia, non-secretory microadenomas. These are usually asymptomatic because they neither secrete hormones nor compress surrounding tissues. Non-secretory macroadenomas. These commonly present with hypopituitarism, due to compression of normal pituitary tissue. Mass effects, resulting from compression of adjacent structures. Mass effects. As a macroadenoma enlarges, it may extend beyond the sella turcica. Superior extension. The tumor compresses the optic chiasm, producing bitemporal hemianopia. This occurs because the crossing nasal retinal fibers are compressed first. Lateral extension. The tumor may invade the cavernous sinus, affecting cranial nerves 3, 4 and 6. Patients develop diplopia, ophthalmoplegia. Now that we have discussed the classification and clinical features of pituitary adenoma, let us move on to their diagnosis and management. Diagnosis. The diagnosis of a pituitary adenoma depends on three main components. Hormonal evaluation, imaging, assessment of visual function. 1. Hormone assays. The slide lists the following baseline investigations. Basal prolactin, IGF-1, 24-hour urine cortisol, Thyroid function tests. These investigations help determine whether the tumor is functioning, secretory, and identify the hormone being overproduced. Prolactin. Serum prolactin is measured to diagnose a prolactinoma, the most common functioning pituitary adenoma. Markedly elevated prolactin levels strongly suggest a prolactinoma. IGF-1. Although growth hormone secretion is pulsatile and varies throughout the day, IGF-1 remains relatively stable. Therefore, IGF-1 is the preferred screening test for growth hormone excess, such as in acromegaly. If IGF-1 is elevated, further confirmation is usually obtained with a growth hormone suppression test using an oral glucose load. 24-hour urinary cortisol. This test screens for hypercortisolism in patients suspected of having an ACTH-secreting pituitary adenoma causing Cushing disease. Thyroid function tests. TSH, free T4, and sometimes free T3 are measured to detect TSH-secreting adenoma, which cause secondary hyperthyroidism. 2. MRI with contrast. Contrast-enhanced MRI of the pituitary is the imaging modality of choice. MRI provides information about tumor size, tumor location, relationship to the optic chiasm, invasion of the cavernous sinus, compression of surrounding structures. It also distinguishes microadenomas from macroadenomas. 3. Perimetry. Perimetry is performed to evaluate the patient's visual fields. This is particularly important in macroadenomas, because enlargement of the tumor may compress the optic chiasm and produce bitemporal hemianopia. Management. Treatment depends on whether the tumor secretes hormones, tumor size, presence of mass effects. Clinical symptoms. 1. Non-secretory microadenomas. No treatment needed. Follow-up with serial MRI. Most non-functioning microadenomas remain stable in size. Therefore, they are usually managed conservatively with periodic MRI, clinical follow-up, hormonal reassessment if indicated. 2. Prolactinomas. Unlike most other pituitary adenoma, prolactinomas are treated medically first. First-line treatment. The treatment of choice is a dopamine agonist, such as cabergoline, bromocriptine. These drugs stimulate dopamine D2 receptors on lactotroph cells, resulting in reduced prolactin secretion, tumor shrinkage, improvement of symptoms. Cabergoline is generally preferred because it is more effective and better tolerated than bromocriptine. Second-line treatment. If medical therapy fails, is not tolerated, or the tumor is resistant, transsphenoidal surgery may be considered. Radiotherapy is reserved for selected cases that are not adequately controlled after surgery. 3. Other secretory adenoma. This group includes growth hormone secreting adenoma, ACTH secreting adenoma, TSH secreting adenoma. First-line treatment. The standard treatment is transsphenoidal hypophysectomy. The aim is to remove the adenoma while preserving normal pituitary tissue whenever possible. Second-line treatment. If surgery is incomplete or unsuccessful, additional treatment may include medical therapy, radiotherapy. The choice depends on the tumor type and the patient's hormonal status. 4. Macroadenomas with mass effects. Large tumors causing compression of adjacent structures usually require surgical decompression. The major indication is compression of the optic chiasm, which threatens vision. Removing the tumor relieves pressure and helps preserve visual function.